Okay, and let's get to the heart of today's presentation. So I'm thrilled to introduce Simon Anderson, who is a colleague of mine here at the center. He started out doing some research work and is now the research coordinator with the center. He has experience as a volunteer himself, working and volunteering in hospice, and is currently a volunteer with CNIB. His interest in palliative care started during his undergraduate degree work when he was working in emergency medicine and found himself wanting to get a closer understanding of the experience of serious illness outside of that emergency room setting. We're thrilled to have him doing this session. He's been doing a lot of work and research and sort of a scoping review of social prescribing in Canada and a little bit around the world as well. So I think he's going to have a lot of good information for all of you. And I will hand it over to Simon now.
Awesome. Thanks, Tina. Thanks so much. Hi, everyone. Nice to be here today. Thank you for joining. I also am calling in today from the traditional ancestral areas of the Squamish, Tsleil-Waututh, and Musqueam people as well. I think I'm just going to dive right into our learning objectives for today. So today I'm hoping that we can, as a group, come away from this session understanding how social connectedness impacts our health. I'm hoping we can also recognize and compare some social prescribing models. And lastly, we're going to have some time to discuss some examples of social prescribing programs. Before I get into this presentation any further, though, I'm going to let Tina launch a poll that we're going to ask you to please respond to. So it'll give us a better understanding of what your current knowledge or experience of social prescribing is. And I'll let that poll be open for a few seconds before we dive into today's content.
So you should see it on the screen. I hope folks do. Oh, yep, I see it filling up. Great, great, great.
Awesome. Okay, I'm just going to move on while people can finish up that poll. So I'm going to begin today by talking about community and its impact on our health. So community and social connectedness is extremely important for our health, both for people living with serious illness and those with life-limiting illnesses as well, but also for those who are close to these people or who are affected by serious illness, such as caregivers and other family. And so part of why community and social connectedness is so important is because we know that in the last year of somebody's life, only about 5% of their time is actually spent within medical settings. The remainder of their time is actually spent in their community, either at home, with family, or engaged in other activities, etc. So for those of us who are interested in palliative care or even just healthcare more generally, we spend most of our time really focused on this 5%. But I think a question we need to consider asking is, how can we support this 95% of the time? And when we ask this question, we can see that communities themselves are actually the ones doing this work to support this 95% of life for patients outside of institutional healthcare. So many communities we know already support and provide services to the frail, to the elderly, to those at the end of life, to caregivers, and even the recently bereaved, in a way that really tackles social isolation and enhances their lives with purpose and meaning. Some well-known examples that I'm sure lots of us are familiar with include things like companionship programs, social networking opportunities, often centered around an activity or a hobby, as well as services for practical everyday tasks like grocery shopping or transportation. This picture shows one of these kind of examples. This is from the seniors community support services offered by an organization in Richmond called Richmond Cares, Richmond Gives. The picture is of one of their services for seniors transportation, an example of a practical service. And so we are familiar with some of these services. Many of us here today are probably involved in these kinds of services, and they really end up becoming quite an invaluable part of care recipients' lives. And the literature has documented some of these benefits. So, for example, those with palliative needs, research has shown that community services can play a specific role in reducing social isolation through psychosocial supports. Additionally, community services can make caring easier for caregivers and dying at home more likely for their family members, largely through the delivery of practical caregiving examples. Practical services like those transportation services. And the benefits of communities are not just for people living with serious illness, but also for the bereaved or those who are grieving from a loss. So, research has actually shown that social connection and social involvement is one of the strongest predictors somebody can have for better psychosocial outcomes after bereavement, while also being one of the greatest protectors against the development of complicated grief or depression for these individuals after a loss. And beyond just the field of palliative care, we know that social connection is important for everyone's health. Research over the years has shown and continues to show that generally, when people are lonely or isolated, they go to the doctor more, they stay in the hospital longer, and they go back to the hospital sooner. Additionally, they are at a greater risk of cardiovascular health events. So we might think that with this understanding of how social connection impacts our health, maybe people are really trying to be less lonely. Maybe loneliness is not as big of a problem because we generally follow the evidence and we want to have better health. Unfortunately, that's actually not the case, and loneliness is actually a growing issue in our society. These figures are from a recent report from the US Surgeon General that describe different measures of social connectedness using data from 2003 all the way to 2020. And moving from left to right across these figures, we see that isolation, measured as the average time spent alone, has increased by 24 hours per month. The average time spent with friends has decreased by 20 hours per month. Social engagement with others has also decreased by 10 hours per month. And companionship, which is measured as the average time spent with somebody for shared leisure or intrinsic satisfaction, has also decreased by 14 hours per month. And so while those pictures highlight an American context, a recent report from the Center for Addiction and Mental Health here in Canada has found that a record high of 24% of Canadians reported loneliness in 2022, which is actually increased from 19% in 2021. So it's kind of important to note that we're coming out of the pandemic, coming out of a time where there's numerous social restrictions, but our social connectedness with each other and with those in our communities is actually getting worse. It's actually a growing issue. And so considering the impacts that this has both in palliative care for palliative patients, but also just for ourselves more generally, this clearly has can have negative consequences for our well-being. And so considering the importance for community that comes at a time when loneliness is a growing issue, social prescribing really represents an opportunity to better people's health. But first, we actually need to talk about what it actually is, because there are some misconceptions around what social prescribing is. So this is a quote from Dr. Kate Mulligan, who is the Senior Director for the Canadian Institute for Social Prescribing. I love this quote. She says that social prescribing is all about shifting the focus from what's the matter with you to what matters to you. I love this very clear description, and I think it really gets to the core of what social prescribing is, which is that it's a patient-centered approach to improve well-being. However, there is a more in-depth definition that was developed earlier this year, and Kate Mulligan was actually an author on this paper. And they define social prescribing as a means for trusted individuals in a clinical and community settings to identify that a person has non-medical health-related social needs and to subsequently connect them to non-clinical supports and services within the community by co-producing a social prescription, which is a non-medical prescription, to improve health and well-being and to strengthen community connections. So this is kind of a dense definition. I think it can kind of be cleared up in a simple picture, which is here. So I think at its core, social prescribing really is about bridging health systems with communities. So right now, the health system is obviously focused on treating medical needs. That's its job. However, many people come through the medical system or see their doctor because of social or non-medical needs related to their social determinants of health. This can include things like education, financial stress, and their built environment. And so social prescribing is all about identifying these individuals and then connecting them to pre-existing social supports in their communities that can begin to address these non-medical needs. So we've talked about the idea of community as being an important role for health. And in previous echo sessions, actually, we've talked about compassionate communities, which is this idea that as a community, we support people living with illness through social and emotional supports, but not everyone knows about these kind of services. Not everyone knows about what's available in their communities. And so not everyone who should be connected or plugged into these services is actually getting connected. And so this is really important thing to note because social prescribing isn't about making a whole new set of services, a whole new set of programs for people to have increased well-being. It's actually about connecting people into pre-existing services that are already offered by the community but may be underutilized. And as a result, social prescribing represents a more holistic approach to caring for patients and promotes community-based integrated care and demedicalizes healthcare. So what social prescribing can actually look like, there's four main models of social prescribing. And the first is actually one that a lot of people don't really associate with social prescribing, but it actually is social prescribing, which is that it's signposting. So in all of these models, on the left side, we have the patient starting in healthcare. So that's that primary care box. And then I'm using the word in this slide activity to basically mean the social prescription. And so in that first model, signposting, this is when a primary care practitioner signposts or refers more information to the patient about an activity or about a social prescription that might work for the patient. The second is direct referral, where the primary care practitioner actually directly refers a patient to a social prescription. The third is a link worker model, where we have this third party individual who receives referrals from health systems. And then they're the ones who do the assessment with the patient to create a social care plan. And then they directly refer that patient to a social prescription. And then the last is similar to the link worker model. It's called the holistic model. Sometimes it's called link worker plus. And this is just the only difference with this fourth model is that there's an emphasis on this continuation of follow-up and evaluation and ongoing assessment with the patient and the link worker, rather than the linear process that's more closely followed in the link worker model number 3. And so research is a bit limited on social prescribing just because it is difficult to actually run a randomized control trial for social prescribing programs because it's such a hard thing to control essentially. But evaluations of social prescribing programs have shown that holistic models have the greatest benefits for patients. Of course, this is also the most resource intensive. So far we've talked about social prescribing in theory, but what does it actually look like in practice? So it can actually look really simple depending on the model of social prescribing you do. So this is a picture of a prescription that went viral on Twitter. This is from a Toronto family doctor who gave a prescription to a patient who is experiencing some feelings of loneliness for a puppy of choice with walks twice daily and lots of love. So I love this example. This is an example of direct referral, social prescribing, where the caregiver or the doctor in this case actually just directly refers a patient to a social prescription. But this is such a great example of some of the creativity that's involved in social prescribing and the real heart of patient-centeredness, where it's really about what matters to you. And for this patient, what mattered to them was connecting with their animal. And so this picture went viral on Twitter because a lot of people were saying, I wish this was my doctor. When I'm feeling down, I don't necessarily need more pills or something like that. I just want somebody to ask me what I would like. And for this patient, what they wanted was a walk with their dog, prescribed by a doctor. So I just love that example. Of course, social prescribing can also look more formal. So this is a program that some people may be familiar with. This is the Seniors Community Connector Program out of Fraser Health. It was started by Dr. Grace Park, and essentially how it works is throughout Fraser Health, the 10 divisions of family practice that exist work with senior serving organizations in each community of Fraser Health, and each partner organization appoints a seniors community connector. That is an equivalent role to the link worker role that we discussed earlier. And in this model, the primary healthcare providers are the ones who assess the needs of the patient, and then if they think they would benefit from the Senior Community Connector program, then they are referred to a Seniors Community Connector. The Seniors Community Connectors are the ones who do client intake, assessment, and social care plan co-creation, and then they refer the patient out to the actual community services and supports the social prescription. And with an aging population, this program's really emphasized that preventative care is the most important. So they've been focusing on preventative care to avoid overburdening acute care services. And due to its huge success and popularity, and it's in the feedback that they're receiving from patients in the program, Fraser Health is extending the program to assisted living homes and acute care, and even hospitals as a way to identify seniors in the health system that may have some barriers to getting home and convalescing and connecting back to their community. So an example of what this program might look like for an actual patient. So this is an example. This is Josie. She's a 72-year-old woman who found out from their doctor that they have dementia. And so they told their primary care provider that they want to remain independent and living at home for as long as possible, but they're worried about depending on others for transportation when they finally have to give up their driver's license. So their primary care doctor told them about social prescribing and referred them to the Maple Ridge Seniors Community Connector program for help and support with their non-medical needs, like physical and social activities, grocery shopping, and transportation. The Seniors Community Connector partnered with them to develop a wellness plan focused on their well-being, and that plan included applying for Handy Dart transportation, setting up meal delivery and light housekeeping services that were going to kick in the future, and enrolling in a program to stay physically and socially active in their community. They were also connected with an Alzheimer's Society support group and a grief counselor. So this is a good example of just how holistic social prescribing can be when the link worker, in this case, the Seniors Community Connector, really addresses all the a total range of social needs that otherwise the health system would not be able to accurately or be able to really address without burdening the health system. And in this way, it's this holistic kind of non-medical approach to caring for Josie. So I'm going to leave us with some resources. If you're interested in social prescribing or wanting to learn more information about how you could get involved or how you could even begin social prescribing, I want to push a number of resources. So the first is from the World Health Organization. This is for a toolkit for implementing social prescribing. So this toolkit was created to introduce social prescribing at the community level, and it outlines some of the steps required to introduce a social prescribing scheme and includes sample materials which can be adapted to a local context. The next is from the National Health Service in the UK, and it's a summary guide on social prescribing and community-based support. It's got a lot of great information about the concept of social prescribing, the role of social prescribing for people, communities, and the system, and some frameworks for evaluating social prescribing programs. And then there's the Alliance for Healthier Communities Social Prescribing Guidebook. This is actually something that was created out of lessons learned through the RX Community program from a social prescribing pilot project in Ontario. And it includes some key steps and recommendations following this pilot. And then lastly, I would encourage everyone to check out the Canadian Institute for Social Prescribing. They have many different online resources covering pretty much any role that you find yourself in, patient, community organization, or in the health system. And however familiar you are with social prescribing, they have something for you. So I would highly recommend checking all these resources out. And I think we can send these resources out to you guys following this echo. So with that, I want to just open the floor for any questions. If you want to contact me, my email is there. I'll show this again. I'll show this slide again at the end of the presentation. Or at the end of our discussion. You can also contact us at conversations@bccpc.ca if you have any questions for us more generally. And yeah, I just want to open the floor for any questions about anything I've said today. And then after that, we'll move into a bit of a discussion time.
So folks can either unmute themselves and ask their question, raise a hand, or pop something into the chat, whatever they are comfortable with. We have a question in the chat. Deb asks, we have a visiting volunteer who happily connects with clients in the community through our hospice. The challenge now is that we are not getting any referrals.
Hmm. Hmm. Yeah, thanks so much for sharing that. I think that is, I think when it comes to social prescribing, there is a lot of information about how to do it, but there isn't much experience about when rubber meets the road, how do you really build those connections with healthcare providers to actually receive referrals? So I think that was going to be, I mean, we'll have some time to discuss this, and I'm hoping maybe other people here today do have connections, and maybe there's a chance to learn from each other about how we can build connections with the health system, because I think that's a real common problem is making yourself known for that health system. When you have these services in place and your side of the bridge is open, but the other side of the bridge, so to speak, to the health system is closed, I'm hoping we can maybe chat about that a little bit more as a group, and maybe people who have had success in that could enlighten us.
Two more questions, and they're kind of interrelated, and actually related even to an extent to the first question. So the second question being, how can you find out if there are any community connectors working in your community? And then the second was, to what extent are family docs incorporating social prescribing into their practice? Is there a level of reluctance? Are there barriers?
Hmm. Yeah, so I think with the first question about how do you find out if somebody is in your area doing social prescribing, I think a common issue in social prescribing is that a lot of people don't know they're doing it. And so they don't call it social prescribing. And so the Seniors Community Connector program that I talked about is kind of a recent push from Fraser Health, and it's actually supported, I didn't mention this, it's supported by United Way. And so they are doing a really good job of calling it social prescribing. They have labeled all their work social prescribing, but a lot of communities and a lot of physicians or healthcare workers in communities are actually already doing social prescribing without knowing it. So I think a good place to start, again, this is not necessarily my wheelhouse, but I think a good place to start would be about connecting with community organizations and trying to get at that bridging piece between the health system. Is the health system aware of community organizations? Are you, if you are in a community organization, do you have any relationships with the healthcare system? Do they know about you? And if you're a physician or if you're a nurse or a nurse practitioner or any type of healthcare worker, are you knowledgeable about social prescribing? Because it doesn't necessarily need to be, I think a lot of people think it needs to be this link worker model, and I don't necessarily think that that is how it always starts. I think if you are a healthcare worker and you're interested in getting involved with social prescribing in some way, I think a good place to start would be about finding out about what services are available in your community that might be beneficial for your patient, sorry, and then you can signpost or directly refer them to those kind of programs. And I think there are a good kind of service that does exist are like Pathways BC. Pathways BC is a great example of an online repository of organizations and services that exist across BC. And so if you're in a specific community, you can look at Pathways BC to identify if there's any services in your area that you might be able to refer people to. Yeah, I think we're getting to some questions. Like, I think a lot of this might come up in our group discussion later on. But yeah.
Great. And I just popped into the link. Simon mentioned the United Way is an organization that provincially is to some degree sort of an umbrella organization around social prescribing. That said, as I think Simon is suggesting, not everybody's doing social prescribing through or under that umbrella.
Mhm.
But I have put the link for the United Way's healthy aging and their social prescribing, and they say there are 19 community agencies across the BC, across the province, that have social prescribing programs. But then there are other programs that sort of lean up against the edges of that, and there might even be representative in today's group with organization programs like the NABCare program, which has quite a wide reach across the province as well. So I'd be interested to know if folks would be wanting us maybe to put together a list or to help at least point you more clearly in the direction of some of those organizations that are doing social prescribing. And you can just put a yes in the chat. That's something you would be interested in.
Yeah, thanks, Tina. That's great. I see a question in the chat about whether I can speak to studies on social prescribing, sample sizes, control conditions, etc. So you will find a lot of evaluations. So right now, like I mentioned, it's hard, kind of the downfall of academia is that randomized controlled trials are kind of the gold standard, which is that way for a reason. They are very rigorous, but as a result, it's really hard, I think, to find quality evidence on social prescribing just because it's really hard to actually control all the different factors that influence somebody's health out in the community. However, there are many different evaluations that have been done both in the UK. The UK is kind of the birthplace of social prescribing. And so one in particular is the Frome Medical Clinic. They ran a very large multi-year kind of trial and evaluation of a social prescribing program that I think lasted 3 to 5 years, I think. And they found a reduction in emergency department admissions for that area compared to the larger area of the region of where that community was in. And so I don't have that like on me, but I would encourage you, we can maybe send out, Tina, do you think we could send out a list of perhaps some evidence sources for people if they were really curious? Obviously, you can see my references as well in my slides. But yeah, I think right now that's kind of a challenge for social prescribing is getting really rigorous data. I think that is going to be pushed in the future. But I would really recommend, again, for you to check out like the Canadian Institute for Social Prescribing. They have tons and tons of evidence summaries. There's been lots of systematic reviews on social prescribing pathways and models. And so, yeah, you kind of have to do a little bit of digging, and we can send out some information to maybe get you started. But if you are curious, there are tons of evaluations. Controls are a little harder to find, like controlled evaluations are a bit harder to find, just because it's difficult to do that. But yeah, I hope I've maybe answered that question.
And I see Sue has noted that she's from the North Shore Community Resources, and they do social prescribing. Yay!
Great. Maybe I can move into some questions I have for people. Okay, so I think when I was thinking about leading a discussion for social prescribing, I think it really came down to I want to hear about people's experiences. And I think people who are doing social prescribing, if we have any community connectors with us today, or if we have any healthcare workers who've referred people, I would love to hear your experiences. And I think oftentimes people want to do social prescribing, but they don't know where to start or how to do it. So I think it kind of comes down to one overarching question, which is, for those of you who are here today, I'm wondering, are you doing social prescribing? And if you are doing social prescribing, which models are you using? Are you using signposting and you never knew that was social prescribing? Are you doing direct referrals? Are you a link worker, or are you involved in a link worker pathway? Or are you doing this holistic link worker model where there's continual follow-up? And if you are doing social prescribing, what's working? And what's working well? What's not working well? What are barriers? And if you're not doing social prescribing, could you see yourself participating in any of these models? And what would you need to start doing it? I think we've already seen some of that about I think something people might need is knowing where a link worker is, or having connections to the health system. So those are great examples. So I'm going to open, the floor. Please feel free to answer any and all of these questions.
I see Florence has her hand up. If you want to unmute and go right ahead.
Thank you very much. Very interesting presentation. I really appreciate it. My organization is called Compassionate Communities Kingston, and we're on the 95% of your chart side. So I just thought I'd tell you what we have going along in Kingston. We are we've decided, we found out about the Froome model about 4 or 5 years ago. So we are adapting the Froome model for our area. And so the components that we have in place, this is, relatively new, so we're not far along in it. We have a research program at Queen's by a professor who's leading it in the health quality side of the Faculty of Health Sciences, and his field is health quality evaluation. We have 2 family health teams that are working with the research side to start implementing social prescribing. One is the Queen's Family Health Team, and the other is a rural group of doctors. And then on the community side, we are Compassionate Communities Kingston, Canada, as part of that international movement of compassionate communities. And we are training that army of citizens to be community connectors to signposts. But we are a volunteer organization with limited resources, but we have been successful in getting some funding, but it is a question of sustainability. So, but there's a lot of interest in it, and that's where we're at. So I just thought I'd tell you what we're doing, that we found the Froome model to be a very interesting model because of their 10 years into it now, and they do have that study, as you said, about reducing emerge visits by 17% in the region and healthcare costs by 21%. And as a result, the NHS is now funding this kind of programming for several in the UK. So they're leaders, as you said. It's the birthplace of social prescribing.
That's great. Thank you so much for sharing that, Florence. That's it's great to hear that people are doing that. That's awesome that that you've really taken on that Froome model. I'm excited to hear maybe more about that. And I'm wondering, I see other people have their hands raised. Does anyone have anything to add to that?
Everyone's being polite. Ellie, do you want to go? I think your hand had gone up next.
Sure, thank you. Yeah, thank you. I don't have anything to add to that. I have more questions than anything. I work for the Pacific Northwest Division of Family Practice up in Smithers in the Northwest here. And we're just creating, like the Bulkley Valley would said, is the first primary care network now starting up, but there's actually 4 more coming all up in the Pacific Northwest. And like probably everybody's aware of, up here in the north, everything is a little different. Where I know my boss would love your presentation, and that's exactly what we always stand for, how we can change and how we can approach it from a social point of view, and how can we help that way. So I think we're very interested to find out more about it. And maybe I was thinking maybe it can be somehow even be included in primary care networks. I think that would be a great addition to it, and maybe the ministry would be open for it. So that was totally excited about it. I personally very passionate about palliative care and hospice and all that. So I think that would be great if somehow we can bring that up to the north of BC. I know the focus is mainly always on down at the Lower Mainland, and there's a lot more people there, so it makes sense. But up here, we need something like that for sure. And it's probably even that people live further apart, that being not having the contact or even don't know about services and stuff is harder to find out up here in the north. So thank you for that.
Yeah, thanks so much. Thanks so much, Ellie. Thanks for saying that. And I really I think what you said is very true. I think we do often bias a lot of our health initiatives and health ideas to the Lower Mainland, and that's definitely a problem. And I think something that's really interesting is that a lot of times, I think what I found helpful when I was learning about social prescribing is knowing that these signposting and direct referral methods are social prescribing, and they have social prescribing benefits, because I think that's really important for communities in more rural and remote settings, because they don't always have the manpower. And maybe you've experienced this in that you don't always have volunteers. You don't always have enough people to work as link workers to have this third party, and so the burden ends up being on the health system. I'm curious, would you say you've experienced that?
Definitely. That's definitely the case up here for sure. And I'm sure like COVID didn't help, right? Like I'm personally trying to set up a hospice training here, and yeah, it's really difficult now since COVID to even, it's starting now, everything is starting very slowly now, but yeah, it has been difficult for sure.
I'm curious, I know there maybe are, Tina, do we have any other hands up right
Yeah,
now?
Sue from the North Shore has her hand up.
Okay.
Hi, sorry, I'm sitting in the sun here, so you can't really see me. But at North Shore Community Resources, we're on the North Shore of Vancouver, and we've had a long-term community navigation center. And when I came in just at the beginning of COVID, who thinks of starting March 30th, 2020, but I did. Anyway, we started to look at the models of social prescribing because it was so valuable for the number of seniors that we were seeing that were coming through with increasing vulnerabilities, and not just one area that they could come and get a referral in, but needing multiple areas. So we studied the models in the UK, and we loved Dr. Marie Essam, who's sometimes called the godmother of social prescribing, who speaks from the UK. She's located in Whatcom area, and looked at the Frome community, and we started to just practice here. We didn't really know what we were doing, but we love what matters to you, not what's the matter with you. And we loved Marie Essam's bent towards saying, look for people who want to walk the extra mile with people. And so that's what we did. And now we have, I think, 5 community connectors working part-time for us. We have one working in Farsi. So that's great because we have a large Iranian community, and doing all kinds of things. Like, we like to try and figure out where some of the plugs in the pipeline are. Like, sometimes food security is an issue, but sometimes there's some plugs in the financial pipeline that can help out. Like things like you're paying way too much for your internet and your TELUS, or you're not getting all the benefits that you should be getting, or you want to go to the rec center, but you don't know how to get there, and it's really scary to go the first time. So we're sending out people to work on all those kind of things, and just finding it really soul satisfying, really personalized, dignified. So loved your presentation, and love this whole idea of social prescribing.
That's great. Thank you. Yeah, thanks. I love hearing about a social prescribing program that's being so successful and working well. I'm curious, you sound like you have experience probably coming up against some barriers and working through them. Would you have any advice for the way you described it? It sounds like you guys really just kind of started to do this, and you just kind of went for it. Do you have any advice for somebody who might be in the same position, who's looking to also just kind of dive in?
Well, I mean, I think some of what helped us is we had what I would say are good bones for it with our community navigation. We put out every year in with the North Shore News. Together, we partner in a seniors directory that tells people all about what kind of things are on the North Shore. So we had also connected a lot with the hospital, with Lionsgate, with the caseworkers, with the discharge workers. We produce a lot of resource materials that are used by everyone across the North Shore, so that helped. We also have connected with the primary care network and the divisions of family practice, and they let us do a webinar for the physicians to tell about what it's all about, and to start to get the referral form into all of their offices. And so, you know, it's a gradual, you know, we'd love to be more connected with fire and paramedics and those kind of areas that can also refer. We had a whole bunch of fans for climate change for the heat wave, so the firemen would come and pick some of them up to take out on the hot weekend. So we're just trying to build that connected, holistic, where there's not just different pillars in society, but we can actually cross refer. The physicians can refer to us, but we can also send people to them that we're concerned about, that we, you know, when we're doing issues like food security or transportation or how people are managing at home or healthcare, that it can be a good two-way street. So we're learning as we go. There's lots of slow times and barriers, but we're really excited. You know, I don't know specifically the barriers, I think, are having the time to get out there and connect and network and outreach so that people know how they can utilize what you have. But I just love that it's so personalized and dignified, and
Yeah,
I'm a firm believer.
that's awesome. That's so great to hear. Thanks so much for sharing that, Sue.
Did you answer my question about reluctance on the part of doctors? Are you finding that?
Oh, yeah, was that a question posed in the chat? Sorry, I think maybe I missed that. So, yeah, I think this is where the third party kind of model really comes into, I think that's one of its strengths, where we don't want to burden the healthcare system. I think that is the main source of physicians or other healthcare workers' kind of hesitancy towards social prescribing. So I haven't come up against any literature that's really done an in-depth and looking at the factors that have maybe led physicians to not engage in social prescribing. I think in some ways there's actually a lot of motivation from the health system to actually do social prescribing, because a lot of times people come into their doctor's appointments with social concerns, with social needs, and the doctors don't necessarily appreciate that their time is being used on non-medical things. And so having a resource to refer them to, I think, is a great motivation. And I think when it's been communicated in that way, as, you know, the link workers or community organizations can address these social needs, and here's where you can refer your patient with a social need too. I think that when it's been communicated in that way, I think that's kind of the getting the foot in the door in terms of the healthcare system. But so I haven't really come up against it. Like in my own, I mean, I don't practice social prescribing. I am a volunteer for this CNIB, like I said, but in that capacity, any relationship I've had with my client's physician has been positive. So I haven't personally experienced that kind of hesitancy for social prescribing from healthcare. But yeah, I'm sure there are resources there. I know the Canadian Institute for Social Prescribing does have resources to talk with healthcare systems about this, and for doctors to learn more about it and learn what they might benefit from when it comes to social prescribing. Yeah.
And maybe what I was going to suggest is, Sue, could you talk a little bit about maybe your experience? Because I got very excited when you said you presented to the, the Division of Family Practice. How did that come about? Did you approach them? Did they approach you?
The Primary Care Network, and that was our mode in. They invited us to speak both to the healthcare team, so the OTs, physios, the primary care nurses, and then they offered us, they have lunch and learn, evening and learn, I think it was, for physicians, where they could come on. It was done on a Zoom as a webinar, and so that was a good way. But I also think that Fraser Health has done a really good job of this with Dr. Grace Parks, who is like a physician champion. We're in Vancouver Coastal Health. We're not quite there yet, I don't think. And but I think that that's the start. And we were scared, like, once we open the door to physicians, are we going to die under the caseload? But when I met with Dr. Grace Park, she said, you know what, it's going to be a trickle to start with. And indeed, for us, it is. And we're pretty interconnected with the hospital. So I think that also really helps. Like, some of the resources they use in discharge for their senior patients are ones that we actually produce. So that builds for us a natural connection. But I think they're suspicious at first. They're like, what are your credentials? We're like, we're very well socially connected. And that's not always enough. But I think as they start to see the fruit of it, it starts like a trickle and grows.
That's great. That's great to hear.
I'm gonna do another follow-up to you, Sue. Sorry, Simon, I'm gonna jump in. I'm wondering if your experience, Sue, had been with that and has been with that, is that helping to define scope of role. In my experience with this role of community, is it's often a question of like, well, is that within scope of role? Who should be doing that? And that's where I've seen and experienced tensions. A little rubbing point sometimes is that, well, you're treading on my territory as a social worker, or are they going to delve into medical advice? So how did you manage that with this early relationship building?
I think my experience was that particularly in COVID, the system was so overloaded that they were just happy to open up the doors and just onto community, whether you were a social prescriber or not. And also too, I think being in the community, so I think we weren't stepping on their toes in that regard. My mother-in-law actually had a stroke towards the end of COVID. And really, we see the caseworker once a year. And she's fabulous, but that there's just so much going on for them that we could fill a role that they couldn't. And we also are less tied. So we are blue sky thinkers. We're like, what can we do in there? So for instance, in the North Shore Emergency Management would work with us because we had a number of fires on the North Shore. And when it displaces seniors, it's a really huge deal because housing is such a big deal. So their volunteers it was out of scope for them to go in and help people move or help with those connections and rebuilding and setting up TELUS and all these kinds of things. So we could fill that part because we weren't as bounded. So I feel like people have been like, thank goodness it's a snowstorm and you're out there moving the seniors, hallelujah, as opposed to feeling like you're stepping on our toes. So in our community, that seems to have worked well.
So yeah, I mean, I think we've talked about some really interesting things. I think it's just so great, Sue, to hear about the work that you are doing on the North Shore. I think that's so great. I'm wondering if anybody else in the chat or anyone else online is interested in doing social prescribing, but maybe doesn't know where to start. Or if is anyone, please don't be afraid to say you disagree and you think social prescribing isn't a good idea, and maybe there's things that need to be sorted out before we do social prescribing. I'll just leave it open for a few more seconds if anyone wants to add any final thoughts on that.
Good question.
Yes, I can take down the presentation.
Yeah. What might be kind of fun if I can stick my oar in again is it would be lovely to know we know because we've organized this, but for those attending, would people be comfortable at least popping into the chat what organization they represent or are from? I think that might be a nice way for you all to see sort of the breadth and width of who is attending today's session that you may want to connect with in some other capacity. Another Ontario, exciting. Okay. Healthy Aging Abbotsford. Oh, Campbell River.
Oh, Comox Valley. I'm from the Comox Valley.
So I think for me, partly what this is also showing is as Simon has been saying, is that I think there's more of us dabbling on the edges of this than we recognize or are labeling as social prescribing, and that it's I think we're kind of on the cusp of seeing a real shift in terms of this sort of, as Simon put it, that bridge between community and the health system. One of my favorite quotes is that systems provide care. In the case of the health system, that's the, you know, clinical interventions that they've been trained for and that we love them for, and that's what we go to see them for. But it's community in most cases that provide care. And that's where we, I think, intuitively know that and experience it, but it's sort of this initiative of social prescribing and compassionate communities. They're sort of bringing to light what was already there. It's revealing what is possible and helping people connect with it. And to me, that's really exciting. That's what's really interesting about this whole concept.
Mm-hmm. It's that 95%.
Yeah.
Yeah.
We've got about 5 minutes left, Simon.
Yeah, okay. So I'm just seeing a comment from Ellie. I believe this kind of work / care is needed. Many more seniors to come. I just wish there was more funding, that not so many volunteers would be needed. I think that's a great point. I think, you know, I think it's hard when you're on the cusp of something because it's a new idea and it's working, but I think a lot of funding models haven't necessarily caught on. And I think what it took, I know in the NHS, was evaluations and kind of really clear impact assessments being done that really showed the impact of this. And I think when the healthcare system in England saw that the Froome medical model reduced healthcare costs by quite a bit, by 21% in the area of Froome compared to the larger area, I think that's what really turned heads. And I think that's when the funding then really started to pour in. So I think it requires a bit of patience on our end, as you know, working in this field, because I think we are on the cusp of this and it is going to grow, but it's just not quite there yet, and we are needing more academic kind of studies on this. But I also think there are initiatives like, for example, the United Way. I know that they do funding for social prescribing programs, and I know that they encourage people to reach out to them if they're interested in starting it. And there's maybe funding models that can take place to support organizations wanting to do that. So I think there are some ways of getting more funding, but it is a challenge. And so I just want to recognize that. I think I'm just going to share my screen for the last couple minutes here, because we do want to kind of push our next session for Echo.
Pulling it up, why don't I give them a
Sounds good.
little teaser? I've just popped into the chat the registration link. Registration is open for our next session in this particular series, our All Together series, which is bringing together the health system and community organizations. And the focus of the session is on developing dementia inclusive spaces for community access, participation, and engagement. So that will be on December let me look at my schedule, December the 5th from 12 to 1 o'clock again. I would also encourage you to check the BC Centre for Palliative Care's website and our Echo page. This is the All Together series is but one of many series of Echoes that we do that you may be interested in. We also have a grief and bereavement series that we are running that is open for everyone, from those that are bereaved through to and including healthcare professionals and administrators and policymakers. And we have a few others that might be of interest to some of you as well. So that link is there if you are interested, and you can also find it on our website, and we'll of course push it again when we send out the resources and the recording for this session for you as well.
Sounds good. Thanks, Tina. Yeah, so that I think that kind of sums up our conversation today. So I want to thank everyone for coming. Again, I'll show this slide. So this is my email. You can please feel free to contact me if you have any questions about anything I talked about today. You can also contact us at the center. We do offer some resources and support for community-based organizations. So we encourage you to reach out if you are interested in any of the work that we are doing or have any questions about how you can get involved. And so that email is conversations@bc-cpc.ca. And I think without further ado, we can probably close it off there. So thanks so much for coming, and I hope everyone has a great rest of the day.
Thank you, everyone.
Thank you.